With improved survival from cancer, there's been a lot of focus on survivorship. In the more recent years, there's been a focus on looking at fear of recurrence. This has been shown to be moderate or to high or clinically significant in up to 50% of cancer survivors. There have not been many trials and interventions, and a lot of health professionals find it difficult to treat this as there's no evidence-based guidelines. We developed a theoretical model on fear of a cancer that people who go through the cancer experience, they have a stress, and many patients will come out with a new norm. People who have unhelpful worries or focus on the cancer or have underlying risk factors or have not been told a lot about what to worry about in their cancer returning have increased fear of recurrence. Based on this model, we developed a Conquer Fear, an intervention, which was to try and modify this fear of cancer recurrence. This was based a lot on metacognition, and metacognition is worrying about worrying. So a cancer patient would think if they didn't worry about the cancer coming back, that it would be more likely that they wouldn't catch it earlier, and therefore they'd have a worse prognosis. We then put this intervention into a clinical trial. We randomised 222 patients with either colon, breast or melanoma. They were all early stage and had to be 2 months to 5 years from diagnosis. In fact, in the trial, 90% of the patients were breast cancer patients. These patients were randomised to the Conquer Fear intervention or Taking It Easy. Conquer Fear was our intervention where the Taking It Easy arm had relaxation sessions. So there were 5 sessions over a period of 10 weeks that these patients underwent. We did baseline, post-intervention and 3 and 6 months surveys. Our primary aim was fear of cancer recurrence. This was shown to be significantly reduced at the end of the treatment and at 3 and 6 months afterwards. The severity of fear of recurrence was also reduced at these time points. Our secondary endpoints of anxiety, quality of life and metacognition were reduced at the end of the intervention, but not significantly at 3 and 6 months. Of interest, both arms had a decrease in all of the endpoints. I think the importance of this study is that fear of cancer recurrence is a real entity, and now there is an intervention that we can actually do to actually help this from occurring, and so people can get on with their life. Fear of recurrence stops people moving on, planning for the future. We're looking in the future to do an economic analysis of this and also to look at doing more cost-effective interventions such as online or community-based intervention.
And it was part of something of a theme in yesterday's conference. There was the talks from Doctors Hess and Rodin as well, which all kind of lends towards this great idea of treating a patient, not the disease.
Yeah, I think it's really important. I think this is growing, that a lot of the focus and funding has been into newer drug treatments, improving survival. But we really need to look at the actual cancer patient as a person and actually make sure that they're surviving the best quality of life they can do.
Especially when you look at, you mentioned the cost, you can spend millions on drugs which might not work, whereas 5 sessions over 10 weeks,
yeah,
it seems much more achievable. Do you think that could be something, a focus for oncologists, clinicians to be aware of, that when you're treating a patient to recommend or even prescribe this kind of?
Oh, I definitely think that it is important. I think, again, it's looking at, there is a cost if you're looking at using psychologists to do it, but I think from a medical oncologist point of view that I think oncologists could actually just tell the patients about what they should worry about would be a start in the help in trying to get them to decrease their fear of recurrence. But certainly I think looking at more cost-effective online ones like Dr. Hess had are certainly looking at very, very achievable and widespread interventions.
Because the SWORD trial was published last month, which was blended cognitive therapy. But they did find that people who didn't complete the trial didn't do quite as well as those who completed all of their sessions. So do you feel like there might be something about patient maintenance, patient adherence to the schedule?
I think it's going to be a combination of online and actual face-to-face or by phone intervention as well.